There's only one big idea that you have to remember here in order to memorize what myocardial infarction does to the QRS complex. And this big idea is drowning in negativity. Why drowning? Well, because when myocardial infarction or necroses occur, it's like someone is pulling the entire QRS complex downward. We'll see what that means in a bit. You should remember that the following two rules apply in the setting of myocardial scarring. Rule number 1. Existing R waves get smaller in the setting of myocardial infarction. So as you know from ventricular hypertrophy, the R wave amplitude correlates with muscle mass. And since myocardial infarction is a loss of muscle mass, it's quite conceivable that myocardial infarction will also lead to a loss of R wave amplitude. And rule number 2, Q waves develop or get deeper. So that's what happens when myocardial infarction occurs. Again, the R waves get smaller or Q waves develop. Just by looking at the leads, we can immediately tell what areas of the heart are affected. Let's repeat what we've learned in level 4.
This is the right ventricle, this is the interventricular septum, and this is the left ventricle.
Now let's relate the leads to the actual areas of the heart that they're depicting. Let's start with leads V1, V2, and V3. They're going through this part of the heart, which is the right ventricle. So when you have changes on the ECG in leads V1, V2, and V3, it's probably the right ventricle that's affected. As you can see here, V2 and V3 also give you information about this area of the heart, which is the basal septum. So when you have changes like myocardial infarction related changes seen in those two leads, it's probably the basal septum that's affected. What about V2, V3, and V4? What if you have changes, let's say an ST elevation in those three leads? As you're going to learn a little later, ST elevations are a sign of myocardial infarction. Well, if you have an ST elevation in those three leads, it's the anterior wall of the left ventricle that's affected. So, as we know, the left ventricle is located behind the right ventricle, but it also has an anterior wall, and this anterior wall is depicted by these three leads. What about V5 and V6? Those two leads show the lateral wall of the left ventricle. And what about V7 and V8? Well, I actually told you already that they're showing you a certain area of the left ventricle, and now you're going to learn which area of the left ventricle that is. That's actually the posterior wall of the left ventricle. This dark green area is the posterior wall of the left ventricle. And every once in a while, V7 and V8 are attached to the patient in order to see if the posterior wall has a problem. And what if you can see changes in V4, so the anterior wall, but also the lateral wall? Well, actually changes that are seen in the anterior wall and the lateral wall are called anterolateral, and changes that are seen in the lateral wall and the posterior wall are called posterolateral. Now let's check out some examples of how the QRS complex morphology changes in the setting of myocardial infarction. In this example, there's an initial Q wave, which you can see right here, even without myocardial infarction. This could be lead V5 or V6, where we would typically see a small Q wave in normal patients. And when myocardial infarction or scar tissue develops underneath that lead, the whole complex gets pulled downward. So the pre-existing Q wave gets much bigger than before and is now 1/3 the size of the R wave. So here are the two settings side by side. Small Q wave without infarction and large Q wave with infarction. These dotted lines clearly show that the R wave amplitude has diminished from the pre-infarction period to the post-infarction period, and the initial small Q wave got a lot deeper. Let's look at another example. In this example, something very similar happens. The QRS complex drowns in negativity. It gets pulled downward so that the initial R wave gets lost and we end up with a QS complex. Here are the two settings side by side. Small R wave, a large S wave in the setting without infarction, and a big QS complex when myocardial infarction developed, so the R wave gets lost. Let's take a look at another example. So this is the typical appearance of leads V3 and V4. In these leads, we usually don't have Q waves, but when infarction occurs, there can be a newly formed Q wave at the beginning of the QRS, as you can see in this example. So side by side again, without infarction, no initial Q wave. With infarction, a newly formed Q wave has developed. There's only one problem, however. As you can see in this image, we normally see small Q waves in leads V5 and V6, and sometimes also in V4. So how will we know if the Qs that we see in the precordial leads are abnormal or not? Let me show you how it's done. Notice how the Qs get bigger as we go from V4 to V5 to V6 in normal patients. Let's look at a patient who has an infarct in the septal and lateral regions. So V4 and V5 are the areas where the infarct is located. And these are also the leads that have the pathologic Q waves. Remember how in the previous example of a healthy patient, the Qs got bigger as we went from V4 to V6. Here, it's the other way around. The Qs are actually getting smaller as we go from V4 to V5 to V6. And that's a sign that something's wrong here. So the rule is that the Qs should get bigger as we go from V4 to V5 to V6. But when they actually get smaller, then that's a sign that there's a problem here, that there might be infarction located in the septolateral regions. However, there's one little caveat to this rule. If the lateral region, that is V6, is also affected by myocardial infarction, as in this image, then Qs won't decrease and we'll end up with an ECG that looks like this. Notice that the Qs are bigger than in normal patients in all three leads, but their size is stable from V4 to V6. One rule that can help you out here is that there should not be any Q waves in leads with deep S waves. So in V4 here, we still have a very deep S wave, and you should definitely not see a Q wave in any lead with an S wave that deep. Now let's take a closer look at leads V1 through V3. This is the normal appearance of all precordial leads. There are two very important facts that you have to remember if you want to master infarction diagnoses. Fact number 1. Leads V1, V2, and V3 usually start with a small initial R wave. So here's the small initial R wave that we almost always see in V1 and V2, and in V3 this R is usually already pretty big. Now for contrast, take a look at this image. This QRS complex also has an R wave, but there's a tiny little Q wave preceding it. So there's a small initial Q wave, and I would say beware of anything that looks like this in leads V1, V2, or V3. You should always think about the possibility of myocardial infarction in this area when you see something like this. Remember, fact number 1 says leads V1, V2, and V3 usually start with a small initial R wave. Let's turn to fact number 2. Fact number 2 says that R wave amplitudes increase as we go from V1 all the way to V5 and V6. If the amplitude does not increase from V1 to V6, or if the amplitude is even decreasing, we also have to think about the possibility of myocardial infarction. Remember, we said that the increase of the R wave represents an increase of muscular mass underneath these leads, and usually muscular mass increases as we go from V1 to V6. So if the R waves don't increase in size, that means that there's a problem of muscular mass underneath the leads of the left ventricle. Let's take a look at some examples. This ECG was taken from a normal patient. Compare that to ECG A. Can you spot the problem? Pause the video and think about the possible solution, and then come back and continue. Have you taken the time to think about it? Good. As you might have realized, there are Q waves in this ECG where there shouldn't be any, or at least they should look differently. They should be smaller, plus they should increase in size. Look, here the Q wave increases as we go from V4 to V5, but then it decreases again. So that's definitely abnormal, but they're also a lot bigger than the cues that we would expect in those leads. So the solution is that this patient had an anterolateral infarct, which is most pronounced in V5. Now take a look at example B. Can you see what the problem is? Again, please pause the video and think about it for a minute or two. Then come back and see how I would solve the case. Ready? Okay, so in this ECG, the thing is that we do have an initial R wave in V1, but I told you the R wave should be getting bigger as we go from V1 to V2 to V3 and furthermore to V6. But what happens here is that the R wave gets lost and that we have one big QS complex in lead V2. And then we have Q waves in lead V3 and V4. So the problem here is that we have scar tissue or an old infarct in regions V2 to V4. What's the problem in example C? Again, pause the video and think about it on your own, then come back and restart the lecture. Pause the video now. The problem in this example is very similar to the previous one, just a little more subtle.
The above image shows you what should actually happen to the R waves. The green line indicates that the R wave should actually increase as we go from V1 to V2 to V3 and so forth. The red line, however, shows you that in the below example, the R waves are not getting bigger from V1 to V2 to V3. They're actually decreasing from V1 to V2 and then staying the same from V2 to V3. So since V2 and V3 represent the basal septum, what we have here is an anteroseptal infarction.
However, in this setting, there's one very important differential diagnosis that you need to be able to exclude before you can be certain that it's truly anteroseptal myocardial infarction. We've already learned about one important disease where there's a tall R in V1 that diminishes in size in V2 and V3. Can you remember what disease that was? That was right ventricular hypertrophy. So whenever you have a case like this one, you should always think back to our Rss criteria. So remember, the Rss criteria for right ventricular hypertrophy are this. You always have to ask yourself, number 1, is the R wave taller than 0.5 millivolt in V1? Number 2, is the R-to-S ratio in V1 above 1? And number 3, is the S in V5 larger than 0.5 millivolt? If that is the case, then you should strongly consider the presence of right ventricular hypertrophy. So let's go back to the case and see how the Rss criteria would apply here. So in this setting, as we said, we would suspect that there is an infarct in the anterior region here because the R is getting smaller from V1 to V2 and staying stable from V2 to V3. But you need to exclude right ventricular hypertrophy in this setting. So you would ask yourself, is the R in V1 above 0.5 millivolt? You don't have the ECG paper in the background, so you can't really tell, but I can tell you it's not bigger. Is the R-to-S ratio above 1? No. The R is smaller than the S. And is the S in V5 bigger than 0.5 millivolt? Again, you can't really tell, but I tell you it's not bigger. So here you could probably exclude right ventricular hypertrophy, and our initial suspicion of anteroseptal myocardial infarction is probably true. Just one more thing. Q waves are considered to be pathologic or abnormal if they're longer than 0.04 seconds or if they're equal to or larger than 1/4 the size of the R wave. You can use these criteria if you're not sure what to do with a Q wave. But don't be too strict. There are some Q waves that don't fulfill these criteria but are abnormal nonetheless.